Pain is a very real thing that our patients experience. Pain can be exhausting, it can be a source of stress, and it can manifest with some real physical symptoms. So we need to be good noticers of pain and also know how to help patients control that. So we're going to be in Giddens chapter 28 and Davis chapter 31. As always, you're going to complete your concept study guide and then define and describe the concept of pain. Notice risk factors for experienced pain, recognize when an individual is in pain, and describe appropriate nursing and collaborative interventions to effectively manage a patient's pain. So let's go ahead and define and describe this concept of pain. So it's a pretty broad definition. Pain is whatever the patient says it is, existing whenever he says it does. The patient's self-report of pain is the most reliable indicator of pain. And while we might see some physical manifestations of pain, really it's up to the patient to report it as subjective data. And whatever their patient says it is what we need to believe and go with it almost always in terms of making sure that we're managing them appropriately. Now, I said almost always because there's certainly going to be drug-seeking behaviors and we want to make sure we're aware of those. But in general, we want to take patients at their word on what they're saying their pain is and go by that. So you'll see in the scope that the pain ranges from no pain to minimal, moderate, and severe pain. And we often rate this on a scale of 0 to 10. And you can see that there's different ways we can describe these pains. We can describe acute pain, meaning happening right now, very recent, new, versus chronic, happening in the long term. Localized versus in a specific area of the body versus generalized body pain. Intermittent, meaning comes and goes, or constant, meaning it's always there. And these are different descriptors we use when we're describing pain. Additional descriptors of pain include these: acute or chronic. Again, is it happening right now and it's new, or is it persistent over a long time? Keep in mind, 1 in 10 Americans have daily chronic pain. You can have something that's a combination of acute and chronic. So you can have someone who has acute, chronic abdominal pain, but today it's much worse. So that would be called acute on chronic abdominal pain. And then you can have intractable pain where there's just nothing we can do to make it better. You also describe pain based on the location, the intensity. Oftentimes we ask for the pain scale for that. And then also the frequency. Does it come and go? Is it constant? Coming and going, being intermittent. Additional descriptors of pain include those done by origin. So you can have cutaneous or superficial pain, which is just on the surface, whereas deep somatic or visceral pain are much deeper. Visceral being a type of pain that cannot be well localized, and deep somatic pain being very specific to a local area like a fracture. You can have radiating pain, pain that moves along an arm or along an area of the body. Phantom pain happens when you have a patient who had like an amputation of a limb, and they could still feel that amputated part hurting even though it's gone because the nerves are still there and they're still firing. And then you can have psychogenic pain. This type of pain is often attributed to things like trauma because it's really pain that's just in the brain, that's just something that the brain is sensing, but there's not actually an attributable cause of it. And often patients who have been trauma victims will have of trauma like violence can have some psychogenic pain associated with that trauma. So you can have different types of classification for pain. The first comes from the nociceptors, and that's just those typical receptors, touch and pressure receptors for sensation. And when they're triggered, they can cause a pain sensation. And this is going to be for things like sunburn, cutting your arm, getting a fracture, having surgery or trauma. Those are all going to trigger those nociceptors to sense pain and send that to the brain. While neuropathic pain, on the other hand, is going to be dealing with those nerves of your body and specific pain triggered and involving those nerves. And patients will describe neuropathic pain as shooting, stabbing, burning, sharp. Those are the types of words that you track along those nerve paths. And you can also have patients who have mixed pain syndrome, which is going to be a combination of your typical nociceptive pain and neuropathic pain. So one is going to be characterized as achy, crampy, throbbing. That's your nociceptive pain. Whereas neuropathic from the nerves is going to be more burning, sharp, or shooting. Pain is something that everyone experiences a little differently, even though the transmission of that into our brain is the same. And so there's different factors that can influence how someone experiences pain. Strong emotions can trigger stronger pain responses, past experiences with pain and how that was dealt with, developmental stages, and how we have the coping mechanisms to be able to deal with our pain. Sociocultural factors, different cultures describe and experience pain differently, both inward and outward. The ability to communicate your pain and be able to communicate your needs can factor pain. And then cognitive impairment. Sometimes we're not able to understand a patient and what they need if they're cognitively delayed. So all of these things can factor into how a patient experiences pain and to what degree. Now, pain left untreated can have major physiological and psychosocial effects on our bodies. So physiologically, we can see an endocrine response where cortisol is released and our blood pressure goes up and our heart rate goes up and our breathing pattern increases. And we can see this respiratory response and physical response to pain. If the pain is caused by mobility, we may see someone decrease their movement and activity because they're concerned about that causing more pain. And not only does this cause physiologic consequences, but psychologically, untreated pain can have consequences as well. Patients can struggle with things like fear, anger that they're experiencing this. They can get depression, anxiety, and even have difficulty maintaining relationships when this pain becomes chronic and just all-encompassing. So what do we need to notice in terms of risk factors for experiencing pain? Well, we know that infants and children are at risk for having higher pain because, again, they have a hard time understanding how to communicate, or parents may not pick up on the cues that infants or children might experience for pain. For our older adult population, we know that older adults are subject to many different procedures and chronic conditions that cause them to be in pain more often. And sometimes providers are more hesitant to prescribe heavily for pain medications for older populations just because of their age and how that factors into their health in general. Now, they've also shown that women have a lower pain tolerance and a lower pain threshold than men do. And there can certainly be a play in terms of cultural or religious convictions that can influence whether someone wants to receive treatment for pain or not. So in addition to this people groups that are at risk, there are also individual risk factors that we should tune into to recognize if our patients as individuals are at risk for having increased pain. So communication barriers, the inability to communicate pain that someone's experiencing. Same thing with cognitive impairment or developmental delay. Mental health conditions. Providers may have a stigma against people with mental health conditions, or they may have been drug seeking in the past and abused different substances, and so providers are less likely to treat them for the pain that they're reporting. Certainly individuals with specific injuries or medical conditions based on the way that injury or medical condition plays out would be at higher risk for having pain. And then unfortunately, there's medical procedures that we have to do in healthcare to help a patient that can cause inherent pain just because of the treatment or the procedure itself. And this is things like inserting a chest tube or drawing blood or putting in an IV. All of those things can cause pain to our patients. or even more extreme, like something like surgery. These things can cause pain, and they are good for the patient in the long run, but they do cause pain in the meantime. So how do we recognize when an individual has pain? What are the signs and symptoms we can look for? Like I said before, we want to go based on the patient's self-report of pain. And here are the things that you would be assessing as elements of your pain assessment. So you're going to look for that self-report of pain. Typically, we use a 0 to 10 number scale if a patient is cognitively and developmentally able to do that. And we're going to ask the patients about their pain. We're going to ask them the location, the intensity, the quality, the onset and duration of the pain. Does anything make it better, make it worse? How is that pain impacting their function and quality of life? And what's their personal goal for comfort and function? Sometimes we can't get a patient's pain score to 0. When my son was in the hospital and had his broken arm, there was no way with 3 brand new pins in his arm that we were going to get to a pain score of 0, but we had to work at what was going to be something that he could tolerate as he was healing. So you might ask something like this: where is this pain? And on a scale of 1 to 10, how bad is it? 10 being the worst. And how would you describe the pain? Is it sharp, dull, achy, burny, throbby? When did it start? Is it constant, or does it come and go? Does anything make it better? Resting, eating something, being in a certain position? How is this pain affecting you? Are you able to function with this pain? Have you had to change your life at all because of this pain? And on a scale of 0 to 10, we may not be able to get you to a 0 today, but what do you think is a reasonable goal we could establish for your comfort and pain goal today? So that's just kind of a quick down and dirty example of how you could use the pain assessment. In addition to a patient's self-report of pain, we can look for behavioral signs: grimacing, restlessness, change in activity, either more activity, more restlessness, or very, very still, and of course, crying. So we need to be able to provide appropriate nursing and collaborative interventions to effectively manage pain. And sometimes this means meds, and sometimes it means non-pharmacological pain management. We don't always want to be med pushers. There are other options out there, and we need to look at the whole toolbox of options for pain management as we consider how to help our patients. So let's start with our non-pharmacological strategies, non-medication ideas. We can do things like massage, positioning, and body alignment to make them more comfortable. We can use splinting, especially for things like sprains or breaks, to help put the patient in a position of comfort and keep their limb or whatever is effective more stable. We can use thermal interventions. Ice packs, hot packs can both be very comforting to a patient. We can use mind-body therapies, things like breathing exercises and relaxation techniques and visualization. And on page 277, there's a great table again of clinical nursing skills for pain. So let's take a look at that together. Go ahead and open up your book. So on page 277 of Giddens, you've got this nice nursing skills for pain, clinical skills that we would need to do. So this is things like doing our pain assessment, like we talked about, doing non-pharmacologic pain management, the massage, splinting, relaxation and guided imagery, distraction. For kids, just giving them a screen and something to watch is often a great way to manage their pain. Oral medications, IV medications, epidural medications. If you've had a baby before and you had a spinal injection for numbing during the labor, that's always helpful. Patient-controlled analgesia, where they hit a pain pump and they hit it on demand. And then local anesthesia, things like a Novocaine shot at the doctor's office. So all of these are different things in our toolbox as nurses, both pharmacological and non-pharmacological, that we can do to help manage pain. Now, in terms of pharmacology, there's certainly 3 analgesic groups that we can use to help in addition to the non-pharmacological methods. So the non-opioid analgesics are things like Tylenol, acetaminophen, NSAIDs, which are your anti-inflammatories like ibuprofen or naproxen. And then you've got your opioids. These are your controlled substances. They're highly addictive, but also highly effective at managing acute pain. things like morphine, fentanyl, hydromorphone, or oxycodone. And then you have some other analgesics that can help in specific situations, things like local anesthetics for things like nerve blocks, dental procedures. You have some good nerve pain medications like gabapentin. And then you have some antidepressants, like some SSRIs, that can really help when there is a brain component, a psychological component to the pain itself. So a couple of nursing considerations for some special groups. First of all, managing pain in the elderly. So we need to recognize that elderly are often undertreated for pain, but often have a very strong response to medications because they metabolize it slower, and so that medication stays in their body longer. So we need to do a careful assessment on pain in the elderly and manage appropriately along with our physicians. Patients with addictions are terribly difficult to manage. First of all, if they do require controlled substances, it often takes more of them to get them under control. But it's also really difficult to work with patients who are drug seeking at managing pain, but also not trying to enable an addiction. And so there are pain specialists out there who will help put together treatment plans, pain plans for these types of patients that we can adhere to. Now, the use of placebos is one of those ethical issues in nursing, and we really discourage the use of placebos because we feel like patients have the right to be informed about their care. And although placebos, meaning giving just like a sugar pill, something fake, although they can actually have a good effect, they aren't a very ethical thing because then the patients aren't really making choices about their treatment. If you want to see how the nursing process would work for pain, there's a really nice evaluation of that in your Davis text on page 822 to 823. So go ahead and read through that on how you would apply the nursing process for pain. When a patient's in pain, it's so hard for them to be able to function and enjoy the quality of their life. Pain can have a consequence and an effect on so many interrelated concepts, including their culture, spirituality, mood, sleep, fatigue, tissue integrity, mobility, function, and development. And so all of those can impact the patient's perception and experience of pain, and then the pain can impact all of those interrelated concepts. You have some exemplars listed in your Giddens text. You can just read through these briefly in your text, as they're not exemplars we're going to focus on for this chapter. It's no fun when you're in pain, and it's something that we as nurses really need to own and be responsible for in helping to manage for our patients. And that includes assessments, doing a really good pain assessment, and it means doing treatments, either non-pharmacological or pharmacologic as ordered. And it means reassessing. And I think we miss that a lot in nursing. So make a commitment to reassess your patients for pain to make sure that they're getting the desired outcomes that they need, or if there's something else that we could do. Thanks for listening.